All right, Chapter 37, Pediatrics Part 1. I divided this into two parts because it's about 300 slides in total. And the first part will be a general sort of overview of the pediatric patient as well as your assessment techniques for the ill or injured child, and then we'll get into some specifics. EMS for children is something that is relatively new in Iowa. As far as the history and legislation of EMS for children goes, we understood that children were not just small adults, and that you couldn't just do everything you do for an adult to a child without taking into account anatomic and physiologic differences. So EMS for children focuses on rapid intervention for sudden cardiac arrest, rapid transport for motor vehicle accidents, equipment, training, and experience is less developed for children than it is for adults. So because of these reasons, in 1984 Congress passed legislation which led to federal funding called Emsc, and Katrina Altenhofen is our state's EMSC coordinator and has worked closely with groups like the Kiwanis in making certain that the proper equipment is available to care for pediatric patients. The purpose of EMSC is to ensure state-of-art emergency medical care for. I'm going to pop that out of there. There we go. To ensure state-of-art emergency medical care for ill or injured children or adolescents, to integrate pediatric services into the EMS system for optimal resources, and it covers the entire spectrum of emergency medical care that we would provide to children or adolescents. As far as injury and illness prevention in children goes, we know that in children, although exsanguination is rare, injuries do cause long-term disability. How, when, and where the injuries occur, identify those children that are at higher risk than other children. In an agricultural state where we have children on the farm around heavy equipment, their potential for injury certainly is greater than those children that are not around heavy equipment. We also have to consider some regional characteristics, the geography, and just like I mentioned, the agricultural community. Certainly the types of injuries we see are different than in an urban setting. Climate and weather conditions, population densities, and population traits, as certain races are more prone to certain types of illness as well. When we look at illness and injury prevention, the key word here is prevention. Most all of deaths related to trauma are unnecessary and can be prevented. And so the whole purpose of injury prevention programs is to put in place measures prior to the injury ever occurring, so that it reduces the likelihood of the injury occurring. Secondary prevention includes preventing or minimizing the injury once it occurs, and then tertiary prevention is to decrease the severity and improve outcome after the injury. So a primary injury prevention would be perhaps a bicycle rodeo, handing out helmets to children riding bicycles. Secondary prevention would be to minimize secondary brain injury following a pediatric versus motor vehicle collision. And tertiary prevention would be getting them to a neurosurgeon or a trauma surgeon quickly. The pediatric chain of survival are events to assess, support, and restore effective ventilation and circulation to children in respiratory arrest. And it's like the American Heart Association chain of survival in because it does address prevention and early CPR, early EMS activation, and early effective advanced life support. In the American Heart Association's adult chain of survival, it's early recognition and then early CPR, early EMS activation, and then effective ALS. So the difference here is a higher emphasis on prevention of the illness or injury from occurring in the first place. Some non-traumatic cardiopulmonary arrest causes include bronchospasm, and I guess the thing before we get into the potential causes is to understand the vast majority of all pediatric arrests are related to a breathing problem. So something to do with a respiratory problem where the child becomes extremely hypoxic, then they become bradycardia as a result of the hypoxia, and that drops their blood pressure to the point where they actually arrest. So some non-traumatic causes of cardiopulmonary arrest in children include bronchospasm, congenital cardiac abnormalities. Here they're talking about things like Wolff-Parkinson's-White syndrome, long QT syndrome, some sort of congenital electrical conduction issue within the heart itself. Dysrhythmias, and it's extremely rare that a child would ever go into ventricular fibrillation. Again, their arrests are almost always asphyxial, and so bradycardia and asystole is the presentation that they have. But that child who is running around on the playground and drops over dead suddenly, or that child who takes a blow to the chest and drops over dead suddenly, might be found in a ventricular fibrillation. Foreign body airway obstruction, gastroenteritis, seizures, particularly status epilepticus, sepsis, very common, drowning, SIDS, upper and lower respiratory tract infections. In assessment of an ill or injured child, it begins like any assessment where you're going to size up the scene. But one thing to keep in mind that children may have illnesses that certainly you don't want to get. They may actively have measles or chickenpox or meningitis or something like that, and so when you have sick kids, particularly with fevers and lots of secretions, it's very important to practice infection control precautions. You're going to assess the scene for hazards, try to identify perhaps a visible mechanism of injury. Your interaction between the child and the caregiver is important. Certainly we know that when assessing a child, that requires a certain degree of I don't want to say finesse, but a certain degree of cautiousness, where we're slowly gaining trust of the child and incorporating both the child and the caregiver in decisions about their assessment and treatment. You get an opportunity to see the orderliness and cleanliness of the home, as well as how safe it is within their living environment. You get a general appearance of the other children in the family that may help you make decisions about, is this a neglectful situation? Is this potential child abuse? You may find some medical devices present, gastric tube, feeding devices, in-home ventilators, CPAP, BiPAP, those sort of things. And then you've all been through a mandatory reporter class and are familiar with the indications for potential physical and mental child abuse as well as neglect. As you size up that scene of the ill or injured child, like any scene, again, you want to ask yourself if you need any additional resources. Law enforcement, particularly if you're thinking this is an abusive situation, fire equipment, motor vehicle collisions, that sort of thing, extrication equipment, special rescue services for high angle stuff, confined space stuff, additional medical personnel, a school bus accident, and then special transport services like ALS needs. When you first walked up to a child, your first impression, or the thing you want to ask yourself is, certainly sick, not sick. We all know what a sick child looks like, and we can use the pediatric assessment triangle to get an idea of whether we're dealing with a sick, not sick child before we even lay hands on them or do an assessment. And we know that younger children need a different approach than older children. Typically with younger children, they've got that fear of separation from their caregiver, perhaps fear of a new stranger or person who's coming into their living space, and so I think it's important that we approach slowly, that we approach with the knowing that it's perfectly okay for the caregiver to hold or coddle the child while you begin your assessment, unless of course you're dealing with a life-threatening emergency. The child may have a sight or hearing problem or a life-threatening problem, in which case you'll have to take over right away. But the pediatric assessment triangle will guide you in determining whether you're dealing with a respiratory problem, a circulatory problem, or a combination of both. Appearance. Some people use tickles as an assessment tool. It deals with tone and interactivity and color and those sort of things to determine whether or not the child's appearance is appropriate for their age. Younger children, of course, who aren't speaking, we have to look at those sort of things to determine mental status. We're going to use Abcde. We're going to look at their muscle tone. Are they moving their extremities well? How is their body positioned? Are their eyes glassed over? Are they crying? Those sort of things help us determine whether we're dealing with a sick or a not sick child. And then anything abnormal should be clue to you, a particular level of consciousness, that you're dealing with either a respiratory or a circulatory problem. So here's that pediatric assessment triangle. We look at ABCs, but the A stands for appearance, and we're going to get a mental status with the Abcde, assess how they're interacting in their environment, how they're interacting with their caregiver, how they interact with you. And then breathing, we're going to look at them to see if there's any increased worker breathing, if you can hear any audible sounds. And then circulation is more about their color. You might pop a quick capillary refill in here, if at all possible, to get an idea. Again, if they appear or they look sick and there's increased worker breathing, you're dealing with a limited number of respiratory problems. If they appear sick and their color's mottled, or if their skin is mottled or pale, you're dealing with a circulatory issue. And there always can be the potential for a combination of both a breathing problem and a circulatory problem, as we'll see in PALS. Worker breathing, certainly worker breathing is evident when we see the presence of visible movement of the chest and abdomen. We see retractions, intercostal retractions. We see seesaw breathing, head bobbing. All those sort of things we'll address or be able to get a look at in PALS. Once we have completed our pediatric assessment triangle and we've done our appearance, our worker breathing, and color, we can move into an Abcde assessment. And you're very familiar with that, where A is airway, B is breathing, C is circulation, D is disability, and here we're looking for neuro stuff, and E is expose, so that we can look for rashes, we can get a good body temperature, we can look for signs of abuse, and again report any abnormal findings. When looking at the skin, in your first impression, prior to doing your hands-on ABCDE, back to your pediatric assessment triangle, you want to look at skin color. It should be pink in most patients, and certainly children of color. We're going to be looking in their conjunctiva, in the inside of their mouth, palms of their hands, the bottom of their feet, for pink skin, because their mucous membrane should be pink. If it's pale or bluish or mottled, then certainly we know that we're dealing with a circulatory problem of some kind. The Abcde assessment, As far as airway, we also want to consider cervical spine, particularly in the pediatric patient who suffered trauma. Stabilize the head and neck until until you get them immobilized if you're suspecting they have a potential for head or neck injuries. Children must have their torso lifted. It keeps their airway in a neutral position. So as you know, when you lie a child flat, their occiput, or the back side of their head, can be really large, causing their head to hyperflex when you lay them flat. So if you get there and their chin's touching their chest because they're really hyperflexed, you need to put something under their shoulders to get them into a neutral position, or at least until the tragus is pointing at the shoulder. And again, we'll point that out in PALS. If they are unresponsive, you're going to do a head tilt chin lift or a jaw thrust, depending upon the situation. You're going to see if they're breathing by listening to their lungs and watching their chest rise and fall. If there is, when you have that airway open, you're going to look inside to see if there's any blood or vomit or secretions. And remember, particularly in younger children, those airways are extremely narrow, and we're going to want to make sure that if they do have any secretions, that we do suction them right away. Breathing and ventilation, you're going to look, listen, and feel. You're going to not necessarily determine a respiratory rate here as much as you are going to know whether it's fast or slow. Look for signs of breathing problems or an increase in worker breathing, like a very anxious appearance, the use of accessory muscles, leaning forward in the tripod position. Nasal flaring occurs pretty early in children when they are in respiratory distress. Their cartilage bands aren't quite as firm as ours are, and so when they start tugging through their nose, they have a tendency to flare their nares. So you'll see that long before you'll see use of accessory muscles and all that other stuff. You may see retractions in the intercostal muscles, the sternocleidomastoid muscles in the neck. You may see seesaw movement where the chest appears to sink down and the belly pouches up, and it's kind of paradoxical. It looks like each one is seesawing back and forth, and that's because they're primarily, the younger children are using their diaphragm to breathe, and our diaphragms are domed. Their diaphragm is flat, and when they start working that diaphragm hard, the belly will pouch out when that diaphragm flattens straight out, but then it has a tendency to pull the chest down, not expand the chest out, because they're not good at using their intercostals, particularly when they're young. And we'll see that in PALS as well. You want to, as you're assessing their breathing, you also want to look at, do they have prolonged inhalation, which would indicate difficulty getting air in. And that might be something you'd see with an upper airway obstruction. Or do they have prolonged expiration, which would indicate they're having trouble getting air out, which is something you might see in lower airway obstruction. You want to listen for breath sounds under the armpit, mid-clavicular, under each clavicle, but more so under the armpit, out on the out towards the outside of their lung fields. Particularly again on smaller children, if I place the stethoscope over their left chest and I hear noises, are those coming from the left chest or am I hearing them from the right chest? Their chest is so small and things are so close together that I may have trouble discerning whether what I'm hearing is coming from the left or right. You want to do certainly begin providing emergency care as you find problems. If they're absent breathing, you want to begin breathing for them. If they've got an open pneumothorax, you want to cover it. If they have a tension pneumothorax, you want to put a hole in their chest. And it's debatable, what cutoff we use to differentiate between respiratory distress and respiratory failure. I think one of the more common beliefs is that, if I'm in respiratory distress, I'm compensating. I'm in distress. I'm working hard. My worker breathing is increased. I'm getting the oxygen I need to my tissues. But when I can't get the oxygen to my tissues, even with my increased worker breathing, then things are going to start to fail. And the first thing to show dysfunction in somebody who's in respiratory distress is the brain. So an altered mental status, the onset of an altered mental status in a child with respiratory distress tells me that they're in respiratory failure, and we need to be much more aggressive with those children. Here's an example of some nasal flaring going on in this young infant. Again, remember that's a very early indicator of respiratory distress. And here's where you're going to look for those retractions. The sternocleidoid, suprasternal muscles, the substernal muscles, intercostal muscles, and the subcostal muscles. Skin turgor. Skin turgor is certainly an assessment that might let you know the hydration status of the child. If their skin turgor is poor, and here they're using in this very small infant, they're just pinching the skin of the abdomen to see if it remains tented, and if it does remain in a tent, then the infant is quite dehydrated. As far as the circulation goes, any external bleeding you're going to want to control right away, because children, and again particularly smaller children, have less blood volume than we do and can't afford to lose as much blood as we can before they go into shock. They do have extremely healthy hearts that are very effective as pumps. So even if they do lose blood and start to go into shock, oftentimes it's unnoticed because their heart does beat so strong and is such a good compensatory mechanism when a child is faced with hemorrhage. Internal bleeding in the chest, the abdomen, the pelvis, the retroperitoneal, the femoral area, those are all possible, particularly in children suffering traumatic injury. May be very difficult to determine. However, if you've got a kid that really looks shocky and you can't find anything anywhere, it's in the chest, the abdomen, or the pelvis. They may have swelling. Their abdomen may be distended and swollen, quite painful. With inside their chest, you might, if you're into percussion, you might be able to hear the hyperresonance that's associated with air in the chest, as well as hyporesonance that's heard as a dull thud when you thump on the chest or abdomen, indicating fluid. When you're assessing the circulation, also you're feeling the pulse to know if it's within the normal limits for their age. Remember that children's heart rates beat faster than ours do, so a sinus tachycardia for us is somewhere between 100 and 150, where a sinus tachycardia for an infant could be somewhere between 100 and 210. So infants' rates, children's rates are much faster. Compare the strength and the quality between the central and peripheral pulses. This will give you a really good idea of their blood pressure. It's very difficult to obtain blood pressures, particularly on smaller children. But if you feel a carotid pulse and compare it to a radial, and they both feel the same, you know the pressure's good. But if you feel a carotid pulse and it's kind of weak and hard to feel, and you can't feel a radial pulse, you know they're hypotensive. So comparing the strength and the quality between the central and peripheral pulses is a good indication of shock. Decreased skin perfusion is of course an indicator of shock in children. Do understand that in newborns they can get what's called acrocyanosis, or cyanosis of the extremities, and that is normal. Typically warm them up and that acrocyanosis goes away. If the extremities are cool or pale, if there's cyanosis around the trunk, again in darker skinned patients or children of color, you're going to have to look in the conjunctiva of the eye, the inside of the mouth, the palm of the hands, bottom of the feet. Mottled skin is certainly an indicator of poor circulation. Checking skin turgor to see for dehydration, as well as assess capillary refill. Now, capillary refill is pinching part of the body and it turns white, letting go, and it should fill back in with color within 2 seconds. And that's a good indicator of circulation in children under 6, as long as they're warm and in a normal environment. If they're in a cold environment, then certainly it's not a good indicator at all. As far as the emergency care during your assessment of the circulation, you want to keep them supine, give them oxygen. If they are bleeding and you can see it, control it with direct pressure and potentially a tourniquet depending on the situation. It's really important to conserve body heat in children. It's important to conserve body heat in all patients who suffer trauma. If we're allowing them to get cold, then their platelets have a hard time sticking together and they have a tendency to bleed more. In addition to that, when they get cold, they're going to shiver and they're going to burn up energy that they just really don't have. And children, because of their body surface area to their actual mass, they have a much larger body surface area compared to their weight than we do as an adult. And because of that, that big body surface area radiates heat, convects heat. If they've sweat or it's wet, the evaporation of that liquid is going to pull off lots of heat. So it's really important that we keep them warm. If they have no pulse or a heart rate less than 60, we need to be doing chest compressions. The thing about the chest compressions is, with children, we press as deep. It's just not as hard to do that. And because of that, most people don't push hard enough on children. If you do it right on a small child, it looks brutal. So it's not being done properly in most situations. With infants, it's in a two-person rescue situation. It's the thumbs encircling the chest and compressing with two thumbs, as well as squeezing with the fingers in a 15:2 compression ventilation ratio. D is the disability, assessing the mental status, and it's just best initially to assess the mental status in children using Abcde. Are they alert? Now, in an adult, we might see that their eyes are open. They may know who they are, where they are, general idea, time, and what happened, and we certainly can use that as well in older children. But in younger children, alert would be their eyes are open, they recognize their caregiver, they're aware of their environment, they acknowledge your presence, those sort of things. If they aren't alert, do they respond to verbal stimulus? And if they don't respond to verbal stimulus, do they respond to pain? And again, I'm a fan of a trapezius pinch when it comes to assessing for pain. And as I mentioned, I think the new curriculum for EMTs is to do put pressure on the eyebrow, because that's a very tender spot as well. And if there's no response to pain, then they're unresponsive. Glasgow Coma Scale has to be adjusted, particularly for smaller children. We'll look at that in more detail later. Smaller children that can't talk aren't going to be able to obey commands or those things, so we have to make adjustments for that. So emergency care during mental status assessment, if they respond only to voice, and they're somnolent or sleepy or fall right back to sleep, you have to make a decision whether you put them in a rescue position or determine whether or not they can manage their own airway. If they only respond to pain or remain unresponsive, certainly that's a high priority patient. Any altered status is a high priority patient, and we need to investigate to see is it hypoxia, is it hypoglycemia, those sort of things. You want to expose them, and certainly remember that as you undress them, if they're awake at all, modesty is something that they, particularly in their early ages, would have concern with. But when you do undress them, to replace their clothing promptly, and that's more to help conserve body heat and address their issues of modesty. Keep their head covered, because I can't, I'm not certain the exact percentage of heat that comes right out of the top of your head, but it's higher in infants and children, again, because of the size of their head in relationship to the rest of their body. If you're able to get a blood pressure, certainly the same rules about a blood pressure cuff apply to children as it does adults. It's got to completely encircle the upper extremity portion. It's got to cover 2/3 of the forearm. But if you're going to struggle getting a blood pressure, use that difference between central and peripheral pulses to know whether or not they're doing okay. Obtain a temperature if you can, either by touching their skin or by an actual thermometer. Children with flushed face or flushed skin, there could be such a wide variety of things, from illness to environmental to toxins. Malaise is just maybe the caregiver says they haven't been able to eat lately, and just haven't feel like eating or doing much of anything. Low energy levels, increased respiratory rates. Increased respiratory rates and increased heart rates are really early indicators of stress in children, perhaps a very early indicator of shock. That increased respiratory rate, where the rate's fast, the worker breathing may be labored a bit, but the lungs are clear, the SATs are good, and there's just no reason they should be breathing that fast. You should be thinking shock, called quiet tachypnea. And then heart rates will elevate, but remember that heart rates are faster in children, and it's not uncommon for a normal heart rate in an infant to be 110, 120. Their eyes may be glassed over, which certainly would indicate that their mentation is not adequate. CUPS is an assessment tool that some people use. We don't commonly use it in Iowa, or at least in my part of Iowa, but I am somewhat familiar with this as an assessment tool. It's identifying whether your patient is critical, unstable, potentially unstable, or stable. And if they are critical, then you provide some initial emergency care and transport immediately. The only thing you worry about in that situation is your ABCs. If they're unstable, you do the same thing. If they're potentially unstable, you can complete your initial assessment, you can provide some emergency care, and then transport. If they're stable, you can actually get a full history, do a good physical exam, all that stuff before you transport. As far as the focused history go, you can determine their mental status by asking a caregiver, is this their normal behavior, particularly if it's a very, very young child or an infant, or is this behavior unusual for them? Try to determine symptom onset. Was it gradual or sudden? Get a history of similar episodes. Did they bump their heads? Do they have a history of diabetes, seizures, poisoning, infections, any sort of fever, any possibility of meningitis or brain tumor? They've been exposed to a toxin. What current medications are they obtaining? Or what current medications are they taking? Assessing their airway and breathing as part of your focused history. Are they having trouble breathing? Does the child have a cough? Does anything make their symptoms better or worse? Are they allergic to any medications, foods, pets, dust, perfume, pollen, cigarette smoke, peanuts? Do they have asthma? Have they had this breathing trouble before? Do they take any medications, either prescription or over the counter? Have they had a recent cold or flu or an earache or pneumonia or other infection that might indicate this is why they're having trouble breathing? Will a child drink? Have they been drooling? A child that's drooling can't swallow, and that certainly might be caused by something like epiglottitis. Have they had a fever? Have they had changes in their voice, where their voice gets real froggy or croaky, or in those particular situations you're thinking more like croup, or at least an upper airway obstruction. Do they have a sibling that's also sick? And then what treatments have already been provided? As far as circulation focus history goes, the amount of blood loss, was there any vomiting or diarrhea, and if so, how often, for how long? If it's a diapered child, have they had normal diapers, or in a dehydrated child, they're not going to pee, so they certainly won't have a lot of wet diapers throughout the day. And assess for poor circulation with capillary refill, and look for signs of shock. As far as your neurological developmental history, particularly in a patient who's unresponsive, do they have any sort of seizure history? And ask questions about that. If they are hot and have a fever, when did it begin? How high did it get? What's been used at this point to reduce the fever? And then transport and reassess for mental status changes. But understand, fever again is a symptom or a sign that something is, could be fighting an infection, could be septic, those sort of things. Children with poisoning. Poisoning can be common in children, not so much as it used to be. A lot of education, injury prevention, poisoning prevention, poison control centers, the way that chemicals are made, have certainly seen some significant changes to decrease the likelihood of poisoning, even if the child got a hold of it and drank quite a bit. So the name of the poison, if it came out of a pill bottle, you know what the date the prescription was filled, you know how many are in there, you know how many times they take it a day, you can see how many's left, and determine, since it was filled, how many should be left, and then if there's a whole bunch missing, then you have an idea of how many they may have taken. When we're talking about poisoning, particularly intentional poisoning, we're typically looking at like a Tylenol overdose. How was it taken? When was it taken? Where was the child found? How long were they alone? Were there any witnesses? Are there other children around? How much was taken? Again, where is it stored? The child's age, and most importantly, the child's weight, because many of the antidotes that we give and medications that ALS will give will be based off weight. So if they can know the weight, they can convert that quickly to kilos and go from there. Do they have any seizures with their poisoning? Any abdominal pain or rashes or behavioral changes? Have they vomited? And if so, how many times? What sort of home remedies were attempted? Did they give them some burnt toast and milk? Did you call a poison control center? If so, what instructions did they give you, and have you provided any of that treatment? Was a child depressed or any sort of recent emotional stress, particularly if you think that you're dealing with a situation of intentional poisoning? You yourself should contact the Poison Control Center and also can ask medical direction for instructions. Always ask for the container and bring it to the hospital with you. With trauma and burns, your history is more on the mechanism. How did the injury occur? Was it a fall? If so, was it greater than their height? Was it a motor vehicle collision? Was it a pedestrian or a bicycle injury? Was there penetrating trauma? Burns? If so, we know the percentage of burns that we use we use a different rule of nines for children than we do adults. If it was a drowning, how long have they been in the water? What type of water was it? What sort of emergency care has been provided? If it's a newborn, as we covered in our neonatal chapter, is the newborn potentially premature based on the due date? Most of these other things are dealing with a baby that's not born yet, like is this the mother's fourth or fifth child? Did the water break? Was there any evidence of meconium staining? Does the mother have any history of recent substance abuse? Prior to newborn delivery, as we covered in neonate, these might be some questions as part of your history. Your physical exam, again, urgent problems that you come across during your physical exam, you should provide initial care for these life-threatening conditions and provide rapid transport. Do a good head-to-toe examination, just like you would for adults, but we start from the toes and work our way up to the head in children. We can do the decap BTLS just as we do for adults. You can auscultate breath sounds, heart sounds. Again, remember with breath sounds, they're best heard out under the arms so that you get away from one side of the chest or the other. As far as the head and face goes, you're going to do your physical exam in a trauma patient, doing your decap BTLS, looking for all those evident signs of trauma. Do remember that when you're dealing with children less than 14 months, We also have the Fontanelles, and the Fontanelles are the soft spots in the skull where the bones of the skull have not yet fused together. I'm not necessarily fan of palpating those soft spots, particularly if there's head trauma, but at least look to see if they're sunken in or puffed out, which might give you an idea as well of perhaps their fluid status, their blood pressure, and the potential for a rise in ICP in the head. You're going to look at their ears for the BTLS. Ecchymosis behind the ears, the Battles sign, an indicator of basilar skull fracture. Look for blood that's coming out of the nose or ears. Might in fact be mixed with cerebral spinal fluid, again indicating a basilar skull fracture. And then feel for tenderness and pain. Look at drainage from the ears as well. Face, BTLS, look for singed facial hair and burns. Facial expression symmetry, to both sides of the mouth come up equally. While rare, children certainly can have strokes, but also in trauma, you could be dealing with an orbit fracture. You could be dealing with a Lefort fracture, where the worst of the Leforts, where the face is completely broken away from the skull itself. The eyes, look for foreign body, look for blood in the anterior chamber of the eye. You'd need a ophthalmoscope for that. Are they wearing eyeglasses or contact lenses? Raccoon's eyes, again a good indicator of basilar skull fracture. Look at the sclera for color. Look at the conjunctiva for color to indicate shock if they're pale. Look for periorbital edema. You want to look at their pupils for equal and reactive. Have them move their, look up, look down, look left, look right. That's a cranial nerve function test. And then the specific pediatric GCS. In the nose, look for blood or fluid, singed nasal hairs, nasal flaring. Feel the nose for potential trauma. In the mouth, the throat, and the pharynx. Again, BTLS, look for blood, broken teeth, vomit, foreign body objects. Injured or swollen tongue, understanding that the tongue in the child is extremely large, fills most of the mouth, and if the tongue were to swell, could be serious and cause a potential airway obstruction. Look at the mucous membranes for color. Again, looking for fluids like vomit. If they're coughing stuff up, what is the color? What is the amount? How consistent is it? Hoarseness or the inability to talk might be an indicator of upper airway obstruction or something like an epiglottitis, and any unusual odors. Checking the neck for jugular vein distension, accessory muscle use. Do they have a stoma? Are they wearing a medic alert? Feel for BTLS. Subcutaneous emphysema in situations where you have perhaps trauma to the trachea, traumatic asphyxiation, overzealous bagging and high airway pressures, causing a pneumomediastinum, which will cause subcutaneous emphysema in the neck. And then the position of the trachea is at midline, and then are they having any other breathing problems or any evidence of shock? Chest, you're looking at worker breathing, movement and symmetry, accessory muscle use, retractions, head bobbing, grunting, all those sort of things would certainly give you an indication that they had some sort of breathing problem. You also want to assess for vascular access devices. Do they have any ports indicating a potential serious illness? Listen to breath sounds, both equal and bilateral. Pick out any abnormal breath sounds. Listen to the heart rate if you're into that kind of thing. If you're hearing stuff louder on one side, again, I like listening out in the armpits rather than on the center of the chest, because it's hard to differentiate between left and right, particularly in smaller children. Chest, you want to feel it for tenderness, expansion, symmetry, any subcutaneous emphysema. The abdomen, look for scars, look for bruises, look for penetrating wounds, potential feeding tubes. Again, they're primarily belly breathers, so they're going to really be working that abdomen during breathing, and if they're in respiratory distress at all, they're going to be working it even harder. Try to auscultate bowel sounds. For the pelvis, might have pelvic pain, might have injury in the genital area, decap BTLS, assess the strength and quality of femoral pulses. As far as the extremity goes, lower extremities first. Again, decap BTLS, look for vascular access devices. Purpura and petechiae are two types of rash that you may see in children. Congenital anomalies, which we'll talk about here in a bit. Abnormal extremity position, and a medic ID bracelet. Again, feel for the decap BTLS. Assess skin temperature, moisture, and capillary refill time in all four extremities. Assess strength, quality of pulses, motor function, sensory function. So circulation, motor, sensory, like we do the adult. If swelling or deformity or tenderness or ecchymosis, then go ahead and immobilize that area. If extremity movement is unequal, then stabilize the spine and immobilize them. That will help immobilize the affected extremity. If an extremity lacks a pulse or sensation, certainly that is a high-risk situation, and they deserve rapid transport. When you roll them over and you're looking at their back, again, looking for decap BTLS, looking for rashes, looking for swelling. Feel the posterior trunk down along the spine for step-off, and again, decap BTLS. En route to the hospital, as part of your reassessment, you want to treat this ill or injured child just like you would any patient, and that is your reassessment would include things as if you've never seen this patient before, going back over your ABCs, going back over vital signs, and trend your results. Your response to emergencies, also remember that in addition to treating the child, you also may have to treat the family. There's nothing more frightening, I would think, as a parent, of having that feeling of hopelessness, that you know your child needs some sort of emergency care, but you don't know how to provide it. And so when the EMS responders get there, again, you may have more than just the patient to treat. Certainly, depending on the seriousness of the illness or the injury, and certainly if the infant or child is deceased, there'll be an immediate grief reaction that you'll have to deal with as well. Try not to separate the child from the caregiver. As far as general management practices, as far as the airway goes, typically the position of comfort works best. Strapping him down, holding him here, doing this, particularly if they struggle a lot, is just really counterproductive. So whatever position they feel best in, if they certainly are awake and wanting to sit up, they can do that. Remember that neck flexion as well as neck flexion, whether it's hyperextended or hyperflexed, either one of those situations will compromise the airway. It also will aggravate a spinal cord injury. Those pediatric patients less than 3 years old may need padding under their torso. And here's that classic picture of the child whose occiput is rather large, and when you lie them flat, you can see that his chin is hyperflexed, and that could potentially cause an obstruction. Not only is the airway partially closed, but then you have to take into account that this child, if they were unconscious, has this really big tongue in relationship to their mouth, and it ends up on the back of their throat. So by putting a towel under their shoulders, you lift them up, you put them into a neutral position, and we'll demonstrate in PALS how we do that. If you believe that the infant or child has a foreign body airway obstruction, you clear it just like you learned in basic life support, with back blows and chest thrusts, and abdominal thrusts for infants. Um, Avoid hypoxia at all costs. Administer oxygen by non-rebreather mask, by blow-by, by bag valve mask ventilation. If you're going to have to, artificially ventilate this child, make sure that you can do that prior to sticking anything in their mouth or nose. But then make sure that if you are going to be bag mask ventilating this child for the any length of time, then size and place an appropriate oropharyngeal airway or nasopharyngeal airway. Bag masks, make sure that you have the right size mask. Here they're saying the 450 to 500 ml bags for newborns, infants, and children, and the standard 1200 ml bag you would use for larger children or adolescents. Positive pressure ventilation will cause gastric distension, particularly if you exceed 19 centimeters of pressure when you ventilate them. If you squeeze that bag with any degree of strength and speed, that's going to generate tremendous pressure in the back of the throat. It's going to open up the esophagus and allow some of the air to go down into the stomach. And the more you do that, the more the stomach will fill up with air. And now you got this big balloon sitting under the diaphragm, and it impedes their ability to breathe. Cricoid pressure is something that we do not teach anymore, so you can forget that bullet point. Endotracheal intubation around a foreign body is certainly something that you may be required to do. If they've got a foreign body aspiration and you cannot remove it with McGill forceps, you may have to try to intubate around that. And then as a very last resort, needle cricothyrotomy. Reassess and confirm position of the tracheal tube. Remember that in children, and I'm sure if you've been doing some clinical and ride and you've gotten some pediatric intubations, their tracheas are extremely tiny, and they're just right at the base of the tongue, and you often overshoot them quite easy. And again, real easy to right main stem them. And then when you're ventilating them, if you're listening to the center of the chest, you'll probably even hear lung sounds on the left, even though you're in the right main stem. So end-tidal CO2 for children as well. That's 100% specific and 100% sensitive for proper advanced airway placement. Gain vascular access. Scalp veins can be used, forearm veins, dorsal hand, just like in adults. Lower extremity veins have kind of lost favor. They're certainly out there, but with the advent of IO, there's really no reason to, access a saphenous vein in the leg. Interosseous infusion. We'll work with this in PALS as well. You can use it to infuse medications, fluid, blood, anything that can be given IV can be given IO. It is delivered into the venous circulation, and depending upon where you start your IO, some faster than others, and you can do it quickly. The old measure was 2 IV attempts or 90 seconds, whichever came first. If it's going to take you more than 2 attempts, or you're still trying 90 seconds later and don't have vascular access in this critical patient, then you'd go to IO. And pretty much anymore, it's go straight to IO. Interosseous infusions, we see them in cardiopulmonary arrest, we see them in shock patients, again, severe hypovolemia, unresponsive patient needing immediate medications, burns, traumatic injuries that prevent access to the venous system otherwise. There's a variety of different sites that you can use, and we'll go through all these in PALS as well. You can use the tibial, the proximal tibia plateau is the most common site. You can use the medial malleolus, you can use the distal femurs, the iliac crests, and now with the easy IOs you can use the femoral head. So you want to do it just like you would an IV. Put on personal protective equipment, have the patient supine, place a towel or a log roll under their knee or behind their knee. Identify your landmarks, and remember when you're doing IOs, it's IO to the big toe. So your IO is always going to be done on the big toe side of anybody's leg. Cleanse the intended insertion site with whatever you use to do IVs. Stabilize the leg. Put the needle at a 90-degree angle to the bone. And then here they're referring to the old Jim Sheedy needle where you twisted it back and forth by hand. But if you're using a bone injection gun or you're using an easy IO drill, you just follow the process for that. When you feel pop stop, you're in the cavity. And then attempt to aspirate bone marrow. You may get bone marrow into the syringe, you may not. If they're severely dehydrated, you're not going to get bone marrow in there. Contraindications to interosseous: if you've got a femoral fracture on the same side, if you have a fracture at or above the insertion site, if there's a severe burn overlying the insertion site, and then that one's relatively contraindicated. It just depends on if that's the only thing you have, then certainly you're going to take that site. Infection at the insertion site, the use of the same bone from an interosseous attempt. So using the same bone, sticking it in the tibial plateau and not successful, and then sticking it in the same tibial plateau rather than going over to the other leg. If they have a congenital bone disorder that may cause fractures. Some possible problems that may be encountered with IO: you don't get through the bony cortex, so you have to make sure your needle's long enough when you begin. You may go completely through the bone and out the other side. If fluid or medications are escaping around the needle through the puncture site, it'll cause infiltration just like it will in an IV. You can fracture the bone. It can lead to a osteomyelitis, a cellulitis, a local abscess, particularly if you're not following good PPE, and may cause a lower extremity compartment syndrome depending upon how the fluids and drugs are administered. Transport considerations: the goal is to stabilize the patient before transport unless you're dealing with severe life threats. En route, use age-appropriate words as you're talking to the child. Keep them warm. Don't delay transport for procedures that you can do en route. Basic life before advanced life, and that's kind of hard for some of these new paramedics coming out of school. They know all these wonderful things that they can do, and they get right after it. But if we don't do basic procedures, a great example is that child that's got an obstructed airway, and we don't even bother trying to ventilate him, or we don't even bother trying to see if we got good chest rise and fall. We just start shoving stuff in people's mouths and end up in a world of hurt. Spine board for bag mask ventilation and CPR, proper restraints, get the information quickly to the hospital. Here are going to be some pictures of some IV sites in children. There's that long, great saphenous vein, and I've not seen anybody hit a saphenous vein to start an IV in a child. I've seen it at the top of the foot at the dorsal venous arch, but not in the saphenous. There's an IO at the tibial tuberosity, the tibial plateau, with that, I'm going to end the presentation with the general assessment stuff. And when we come back with part 2, I'm going to get into respiratory compromise and lower airway diseases. So we'll talk about croup and epiglottitis and bacterial tracheitis, as well as asthma, bronchiolitis, and pneumonia. So I'll talk to you soon.